I want to introduce everyone to Noah Warren. I'm super excited. I know I say this every week and every time we have one of these meetings, and it is truly because I develop a personal relationship with all the facilities in our network, and I really believe in them. But I am particularly attached to Roots to Recovery because like maybe 6 years ago,
seven years ago,
when I had the idea for Recover Well, I reached out to Noah and Nicole, and they were also simultaneously building their program, and they invited me in to work with them, and I learned a lot from them. And Noah in particular was so supportive of what I was trying to do and was excited about the idea, even introduced me to a couple potential investors, and really got behind what I was doing, and then became a member of our network early on, and has been just a great supporter. So I'm super happy. And I will tell you that Roots to Recovery operates very much like a high-end luxury treatment center. And they serve all clients. So just like Twin Town up in Sherman Oaks, that's our great resource for our Valley patients. Long Beach has a beautiful program that serves all patients equally, and really makes a great effort at doing that. I can't stress this enough. When I see a facility that could just rest on taking Cigna insurance, United insurance, but goes out of their way and works very, very hard to get in network with Medi-Cal and Medicare, Medicaid, any of these public facing programs. I love that they're doing that work, because it means they're there for all patients, and that they're there to disrupt the disparity that exists between people. And I want to give this number. There, 1/32, that fraction, 1/32 of treatment providers serve patients with Medicaid throughout this country.
Wow.
Which is absolutely heartbreaking. So when we hear people make this statement, oh, it's a poor people's disease, oh, it's a disease of the lower socioeconomic group of folks, oh, it's a disease of this demographic or that demographic, or the others that they like to call out, those people represent a percentage of the population that are fighting for 1/32 of available services. I'm going to mute everybody. Hold on. How do I do that? I always forget.
If everything sounds good here, then you just sign where it says patient signature.
Hey folks, how do I mute? Somebody always chimes in and tells me. I forget.
Yeah.
I'm not sure how to do that.
I'm not sure how to do it either. Let's see. Hold on. Be here? No.
If you go to the participants list, you should be able to see a
Oh, okay.
mute all at the bottom.
Oh yeah. Mute all. Okay. Anyway, that's my rant and rave for today. Just when you see a facility like Roots to Recovery or Twin Town Treatment Centers that are out there providing these services to all patients, keep in mind that they worked really hard to get into a network like Medi-Cal that typically doesn't pay out as much, and they are serving the most underserved population. And that's love. So please consider them. And their facilities, both the Roots to Recovery and Twin Town, are gorgeous. It's like for high-end luxury clientele. So yeah, that's my spiel. Without further ado, I want to hand it over to Noah and have him share his screen and introduce himself and the program.
Thank you so much for that great introduction. It's saying that I don't have screen sharing capabilities yet. There we go. Thank you. Yes, I'm so happy to be here with all of you today. And as Amy said, she was our first outside staff member that came in to help us get the name out there. And, you know, a lot of things have changed, but most things are still the same. And like how we approach treatment from a trauma focused standpoint. And yeah, so I love to tell you more about what we're doing. We started with Roots to Recovery, which focuses on substance use disorders and co-occurring disorders. We also provide addiction medicine, PHP, IOP, OP levels of care, and that's for ages 13 and up. In the last few years, we opened up Roots Mental Wellness, which is our primary mental health program, serves ages 13 and up as well for most of the services and programs, all outpatient levels of care. So these patients, a lot of them don't have any history of substance use, so we are able to provide treatment to those folks as well. We also provide standalone psychiatry and med management services and TMS therapy and ketamine assisted psychotherapy, which I'll get into a little bit more. As I said, we opened up in 2016 as we saw this need arise to treat the primary mental health population. We started expanding our services, started with TMS, and then we added ketamine. And then in 2021, after many years, as Amy alluded to, of battling with the state and the county, we got our DMC contract. And so we were able to open up to our IOP and OP services to Medi-Cal beneficiaries. And that is for primary SUD. So we can treat primary SUD and co-occurring disorders in our DMC program. And then last year, we started our adolescent program, treating ages 13 and up, both SUD, co-occurring, and mental health. And then just in the last 2 months, we got approval to expand our DMC services to the adolescent population as well. As I mentioned, we are trauma focused. You know, we from the very beginning have, you know, founded our company on the idea that underneath everything, substance use, mental health conditions, you know, everything is based on unresolved trauma. So if you can identify that and uncover it and provide people with the tools to develop resilience, you know, then they're able to break the trauma cycle. So that is the foundation of our program, resolving trauma using EMDR, DBT, mindfulness practices, and then giving them the tools to build resiliency. So our leadership team, so we have 2 physicians on site, 1 psychiatrist, a nurse practitioner, psychiatric nurse practitioner, 2 clinical psychologists, and then a full team of clinicians, 5 full-time therapists, case managers, counselors. And then we also bring in a lot of outside contract facilitators for groups, both to, you know, fill needs so that our therapists can focus on individual and family therapy, but also to bring in more engaging, fun, exciting groups, and for our clients to see different faces throughout the day and not just their therapist and case manager all day long. What we treat, so obviously trauma and PTSD. We also work closely with the military and developing some contracts right now with the Navy to treat obviously combat trauma, but also a specialized program for military sexual trauma, depression, anxiety, bipolar disorder, all co-occurring disorders. And then we have our substance use program where we're able to treat all of the SUD. So I'm not going to go through all of this. You can sort of glance at all of the different program components, but this is really just to give you an idea of how comprehensive our program is. At intake, all of our clients are provided they're assigned a primary therapist, a case manager, and a family therapist. And each of those clinicians plays a different role in their program. It's a mix of individual, group, family therapy, case management, and depending on their treatment plan, in collaboration with the psychiatrist and all of the providers, each person's program looks very different. I know individualized care is a buzzword in our industry, but no two treatment programs look alike for our clients. So if somebody needs additional case management, their program is heavy on case management. If they've, family systems issues, there's a huge family component to their program, and it's going to look different for everyone. But we bring in a lot of experiential groups and a lot of skills-based groups. All of our clinicians are trained in EMDR. So if there's PTSD or trauma, they're addressing that in individual therapy. So our SUD and co-occurring services, is sort of a recap of what I said, but I think the main takeaway here, I want to hammer home that our SUD and co-occurring program, we have PHP, IOP, and OP, and adolescents and adults, and we can take commercial insurance and Medi-Cal for SUD and co-occurring. For primary mental health, similarly, the programs obviously look the same for PHP, IOP, but we're able to also provide standalone psychiatric services, psych evals, medication management, TMS, and CAP. And currently, we're in the process of negotiating a contract with DMH, but for right now, only commercial insurance is accepted in our primary mental health program. For those of you that aren't familiar with TMS, I don't know how widely known this treatment is, but TMS is an effective alternative to medication for treatment-resistant depression. One of the main issues that we find with patients that are being referred to us by psychiatrists is that most patients stop taking antidepressants within the first month. And the data that shows, if somebody fails the first antidepressant regimen, the efficacy goes down to like 7% by the third trial. And there's about an 83% response rate with TMS. And so with our TMS program, to get a psych eval, the psychiatrist does the mapping, and then there's 30 treatment sessions, 5 days a week for 6 weeks. And with Theta Burst, which is offered by the machine that we use, the treatment can be as few as 3 minutes. So a lot of people come in during their lunch break or before or after work. And then we also provide weekly psych follow-ups, and then there's a post-treatment psych eval. The great thing about TMS is that because it's non-systemic, there are very few side effects. Obviously, if somebody has like a predisposure to having seizures or different things like that, bipolar disorders, contraindication, you have to screen people out that could potentially experience side effects from TMS. But it is FDA cleared for treatment-resistant depression and OCD now, and so it's covered by most insurance. Ketamine-assisted psychotherapy is something that we started offering in the last year. It is extremely effective with people who have treatment-resistant depression. Oftentimes, people will explore either CAP or TMS. And again, it's heavy on the screening, making sure that people are appropriate for this treatment. The psychiatrist does an evaluation, and then our clinical psychologist, who is actually providing the psychotherapy, does an extensive evaluation as well. We do 3 preparation sessions before any dosing of the ketamine, and we offer sublingual and oral. We're in the process of getting signed on to be to offer Spravato, which is intranasal and covered by insurance. And following each of the dosing sessions, there's an integration session so that people are able to process what they're experiencing during the ketamine treatment. The outcomes are durable. You know, we've seen really great success, and that's partly because it's integrated into the treatment plan. We're not a ketamine mill. Somebody wants to just come in and get ketamine, they got to go somewhere else. It's a part of a psychotherapy program, and it's just a tool to help people bridge the gap. Last year, really proud to say that we received the Conquer Addiction Excellence in Treatment Award for our post-treatment outcomes. We use a third party called Vista Research Group to track all of our outcomes at intake, throughout treatment, at discharge, and then post-discharge. And so these are some of the data that we have no control over, but I'm happy to present this to you. One of the key takeaways is we've shown 100% reduction in suicide plans, psychosis, and mania symptoms from intake to discharge. Our in-network contracts, we are a proud contractor for TRICARE, been in their network since 2018, work really closely with the military, active duty dependents and veterans, HealthNet and MHN, and then Medi-Cal for our SED and co-occurring adolescent and adult programs. And we also have an ILWU contract for SED. For primary mental health, the same, except not Medi-Cal at this time. And then we're able to work with most PPO policies out of network. We do offer payment plans for people who are struggling with their co-insurance, whatever their patient responsibility is. So we're able to work with people. Pretty standard, our process, we do an assessment. Oftentimes people will want to tour our facility, which we're open to at any time. Our team will make a clinical decision and then schedule an intake that works for the patient and our team. And this is how to contact us, but obviously you'll contact us through RecoverWell. And then we have like virtual tours of both our housing program and our outpatient here that people can scan at a later time and check out. One thing I did want to mention that I don't have a slide for here, checking the time, is that we do have gender-specific sober living homes in Long Beach. They are near Cal State Long, a very nice neighborhood, beautiful homes. Transportation to and from treatment is provided, and transportation to appointments, anything recovery related or medical related, we provide transportation. It's $1,500 a month. We do accept pets on a case-to-case basis. And I actually shouldn't have said sober living, because it's actually now, I think, probably heavier on the mental health side. So all of our supportive housing staff are also trained in trauma-focused care, medication management. And so people that are on medications can bring those to the housing, and we keep them locked up and obviously observe self-administration at certain times throughout the day. And with that, I will open it up to any questions. I know that was a lot of information in a short amount of time, so I try to speed through it quickly. So I would love any questions.
Great presentation. I want to just drill home a couple of points. So I know that the big challenges for a lot of our patients are transportation, which you covered that said that transportation was provided. So is that transportation provided to and from when they're living in your supportive housing?
Yeah, yes.
Okay. And let's talk about supportive housing a little bit more in depth. So if they're in the IOP PHP program, supportive housing is either sober living or transitional housing,
Yeah.
as you described, with secure lock boxes for medications and a lot of oversight and supervision. Can you talk about how that's funded and how people would like talk about what the cost is for that a little bit? I think
Yeah.
you said 1,500, but explain
Yeah.
why that is not part of the insured patient's cost.
Yes. So in the state of California, there's a law that dictates that that the insurance companies will not pay for housing at the outpatient level. If you're paying for housing, it's because you're in a residential program, which is why somebody would authorize an RTC or inpatient level of care. So if the insurance is authorizing PHP, IOP, or OP, they say they should be living in the community. And so that insurance money cannot go toward housing because it's not a medically necessary service. Now, because we also accept private insurance, we're not able to just provide housing because they look at that as us using the insurance money to pay for the housing program. So it's required that people pay for the housing out of pocket. There are housing vouchers that people can get. There's other kinds of financial support. If somebody is on Medi-Cal or or is on disability, there's additional support that can be used to pay for housing. We also work with other local providers in Long Beach if people can't afford that price point. So there are some that we work with that are also really great programs that are like $600 a month. And we are looking at opening up a house that's cheaper, that's in maybe a different area of Long Beach, because real estate's expensive.
Yeah.
and it's expensive. Our program is a little pricey for Long Beach, but we have a live-in house manager and 24-hour support staff on different shifts. So it's not just a sober living where people lay their head at night.
And does that cost for the 1,500 or whatever the rent cost, that does not include food, correct?
There is basic food provided in the house, like staples. But if people want, outside food, other things, oftentimes people will get, they'll, have food stamps or, SNAP or something, and they're able to use that to go grocery shopping. And we take them grocery shopping and everybody's food is separated. But sometimes, the clients choose to like cook together and eat together. So, and our housing program is not exclusive to Roots. So I'd say about half of our housing residents are not Roots clients. They come from other treatment centers, or they've already completed treatment.
Okay, cool. I wanted to ask, that was my next question. These programs and the supportive housing are not mutually exclusive, so they can
Correct.
attend IOP, PHP and live at home or at another facility. Okay.
Correct. Yeah.
Okay.
Yeah.
All right. So those were my questions. Anybody else? Kirsty asked, do you provide free trial to KAP to professionals to understand the experience of it for the ketamine therapy?
Ask the question again. I'm sorry. I just want to make sure I understood.
Do you provide free trial of KAP to professionals to understand the experience of it?
It is something that we would consider on a case case by case. Obviously, our psychiatrists and our psychologists, they collaborate on every case and want to make sure that people are screened and appropriate. But if we're not doing Spravato, which you have to have approval by the insurance company to use Spravato. If it's a sublingual or an oral ketamine, we could do that. So it's definitely something that we talked about recently, actually, because we also had some of our outpatient staff who were interested in trying it before they get trained up to be a CAP therapist.
Okay, any other questions about the program, where it's located, the providers that work there? Any questions about specialty? I know you talked about TMS, which TMS is like relatively new to the treatment world as being part of the patient experience. I know that it's been extremely successful for a lot of patients with PTSD at the VA. So it makes sense that you would have that available there. And I hear amazing things about the experience, where EMDR was sort of reprogramming brains out of trauma. I think TMS is like the next innovative big treatment for that. So
yeah, absolutely. And we were lucky enough to bring on our TMS medical director, who's a psychiatrist. He's the president of the TMS Society. And he's been a part of most of the TMS research since it was brought over to the United States. And so he's amazing, and he's gotten us. We're exploring a clinical trial right now for TMS to treat cravings and other SUD related issues. So because there hasn't been research on that yet.
Just to clarify, the ketamine therapy, which is also like so new and exciting. And I think everybody's excited about this because not many places are offering it. But it is definitely just something that has been on radar for people for years. And now that it's available, is it available under supervision for patients who come in for primary substance use, or is it only available for primary mental health? I'm sorry if you covered that and I missed it.
No, yeah, we actually have quite a few of our co-occurring patients who are interested in exploring the use of CAP. If somebody's got alcohol use disorder or opioid dependence, and it's obviously linked to PTSD, trauma, major depression, some of these things, CAP could be a good option for them. And again, it's meant to just be used as a tool to help bridge the gap in psychotherapy. So it's heavy on the preparation sessions, heavy on the integration sessions, and really making sure that people are having this experience, are processing all of the information, because that's really all it's meant to do, is to help people sort of, dissolve the ego and dissociate so that they can allow new information and experiences to come through. Because we have this thing, the default mode network, that we've trained really well throughout our lives to filter out things that we think aren't important, which is informed by all these biases and inputs from social media, everything. So the way we were raised. And so it allows people to have these breakthroughs in treatment that they wouldn't otherwise be able to have. So we're also, this may be a little premature, but we also are doing some work down in San Diego, and exploring a clinical trial for MDMA to treat PTSD with veterans. Maybe active duty if this bill passes through Congress, we'll see. But as of right now, psychedelics are off the table for active duty service members, but we are looking at doing something with the veterans down here in San Diego.
Nice. Sweet. That's amazing. And I think if Alicia Abate is on this call, she's down in San Diego, and I'm working with her on getting some more resources down there. So she'll be eager to hear what services you will be offering in San Diego, like the minute you turn those on. So
Okay, yeah, we're gonna open up an outpatient center down here in San Diego. I'm in San Diego.
awesome. Because we have a number of scripts and sharp people on the platform that are like
Great.
reaching out to me regularly, like, when are you gonna have more stuff down here? So that's awesome news. I'm so excited. I'm glad you mentioned that. All right, well, I'm gonna in the interest of everyone's time, I'm gonna announce our winner for today, and I promise I've been so delayed in sending out everybody's gift cards and stuff, but I'll do that over the weekend, this weekend, so forgive me if I owe you a gift card. I have a list. So all right, our winner for today is April Navas. You are the winner. Yay.
Congrats,
Okay.
April.
All right. So April, I'll send that over to you over the weekend, and everybody have a
Thank
fabulous
you.
weekend. I hope people get some time off to reset and renew. And Noah, thank you. Noah will be back again to do another one for our Tuesday group, and hopefully you guys can tune in, spread the word. We'll do another one also for Twin Town in November. So we've got lots of good things coming up. So stay tuned. You guys, on our website, there's now a menu of all the different things that we have going on. So when you can check the events page on our website, we've got lots of contests coming up. The next one we're going to do AirPods. So get in there and get involved and keep doing this amazing work. I can't thank all of you enough. I genuinely love everybody on this call. You're doing the best work possible. So have a wonderful weekend, and
Thank you, everyone. I appreciate the opportunity. Have a good one.
Thank you. Take care. Bye.
Bye.